Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zires, and each week I'm joined by my residency buddies, Laura Ferris and Tim Patton, to use our 60 years of combined experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major podcast platforms. The video component, for those who haven't checked it out, has the key figures and tables from the articles we talk about. The episode description also has a link that'll get you to the links to the articles and any other resources we might discuss on the episode. So let's go ahead and get into it. This week, we have got a fantastic episode. We are going to do a deep dive into bullous pemphigoid, and then we are going to be joined with our expert guest, Dr. Donna Culton from the University of North Carolina. So let's go ahead and get into it. I'm going to lead us off with an article that fortuitously just published in JAD that was a clinical review on bullous pemphigoid. And really, this is me just hitting some of the highlights of pemphigoid, kind of a quick review for anybody who hasn't seen a case recently and really thought it through. The key things from this clinical review is to remember that 20% of people have no blisters. You can have mucosal involvement in up to 30% of patients, and mucosal involvement is usually a marker for worse disease that's going to be harder to treat. Itching can precede blisters by months, but if itching is caused by pemphigoid, if you do a biopsy, there should be a positive DIF or serologies. It's an interesting question that we'll kind of get into a little bit is, do we think that's underdiagnosed? Because, you know, if I see somebody who's itching, if they've got red blotches, I'm likely to biopsy them, but if they don't, I might not. Then we've got drug-induced pemphigoid, the big drug, the hot thing causing that, or the dipeptidylpeptidase 4 inhibitors, or the gliptins and spironolactone. Those are apparently the two most common drugs. Tends to be younger patients, worse blisters, good response to therapy. 1% of people who are on immune checkpoint inhibitors can get a induced pemphigoid. Can be bad enough that they need to stop the drug. Treatment's still necessary, as it may not go away once that genie's out of the bottle. And then with drug-induced, whether it's a dipeptidylpeptidase 4 or spironolactone, and I'll be interested to hear what our guests and my co-hosts have to say, you don't want to treat gently hoping it'll go away. You treat for real, but you try to stop sooner if they're doing great after they've discontinued the drug. And then the last thing for H&E, for the biopsy, you want to biopsy either an entire intact blister or the edge of a blister. Then for the immunofluorescence, you want to biopsy non-bullous inflamed skin within a couple centimeters of a blister. Now, one of the questions that I'm going to have for our guest and my co-host is, what if there's no non-inflamed skin next to the blisters? What if it's just a blister? You just biopsy right next to it, I guess. And then we should, whenever we suspect the diagnosis or after we get it, be ordering ELISAs for BP 180 and BP 230. Might use indirect immunofluorescence if you've got a weird case, but you need a good lab if you're going to do that. So those were I'm not going to really get into the treatment because we're going to talk about that at length as we go forward. But Drs. Patton and Ferris, anything else you guys want to add that is kind of big picture stuff for bullous pemphigoid before we move on?
Those are good points. So remind us which issue of the JAD was this review in? I looked at it quickly, but it seemed like a great resource for people like me who don't treat this every day.
It was just published June of 2025, and Dr. Culton, our guest, was one of the authors on the paper.
Great. Thank you.
All right. So
yeah, I thought that was a good review. You may have said it. One of the things that always stands out to me with the immune checkpoint inhibitor therapy is it could be like a year or even 2 years after that medication is discontinued. So there can be a pretty significant delay in that ICI induced.
Is that, I mean, would we even really consider that ICI? Isn't it just possible that an old person got pemphigoid?
Good question.
Yeah, hard to know. Hard to know.
I think if you did one of those
latency for the DPP4 inhibitors, what's that time? Like how long is that onset?
That's a good question, because I mean, I'll be interested to see what Dr. Culton says with DPP4 inhibitors. I mean, some of those patients honestly have been on DPP4 inhibitors for years. I think of that less like oh yes, this medication definitely triggered it, as opposed to I mean, maybe you triggered it, but you're on this DPP4 inhibitor. There's a reason why that could make the pemphigoid more difficult to treat. So we should get you off it regardless. But a fair number of times, it's not like, hey, discontinue the med and then you don't need to treat. I have found that, if you get lucky, you discontinue the med and they get better. But a lot of those patients need treatment. I think if you kept them on the DPP4 inhibitor, that treatment might be a little bit more challenging, might have to be a little bit more aggressive.
And the problem is that it like molecularly mimics the NC16A domain or something like that, correct?
Oh, I don't think so. No, my understanding is the DPP4, so it's a dipeptyl peptidase. They inhibit that. Those dipeptyl peptidases, they break down things that are important for, if you inhibit it, you get these proteins that help you manage sugars. But things like eotaxin are also broken down by the dipeptyl peptidase for that enzyme. So what you're inhibiting is there are more things that DPPs break down that maybe have nothing to do with diabetes, but they could play a role in making BP more active. Eotaxin is like the big one. I think there's another cytokine, CXCR, one of those guys that it breaks down. And by not breaking that down, that could contribute to kind of the inflammatory milieu that you see with BP.
Oh, interesting. Okay. Well, let's go ahead and move on to our second article. Dr. Ferris, what do you got?
Okay, so I have actually a recently published paper in the Journal of Dermatology. Gianluca Avallone, and I'm sure I'm saying that wrong at all. So this is effectiveness of dupilumab and omalizumab and bullous pemphigoid, a nationwide retrospective cohort study. So this is basically a retrospective review, 58 patients with BP. They actually did include, patients who had checkpoint inhibitor or gliptin associated BP. So this is sort of more real world versus what you might see in a clinical trial. And so about 2/3 of these patients ended up being treated with dupilumab and about 1/3 with omalizumab. And so again, this was not randomized. This is retrospective. Overall, the omalizumab group seemed to actually have a little bit more severe disease, so longer duration, higher BP, DAI, sort of one of the outcome measures of BP, higher titers, higher DLQI, more prednisone at baseline. So the primary outcome that they looked at were a proportion of patients who had disease control within 8 weeks and then at the end of follow-up. And they called that like no new lesions, no pruritus, all the existing lesions that they had were healing. And then they also looked at things like complete or partial remission on minimal or no therapy. So, overall, what did they see? The dupilumab group actually seemed to do a little bit better. So their disease control rate was a little bit higher, about 56% versus 27%. And at the end of follow-up, it was higher, like 90 versus 78%, and a little bit of lower relapse. So, kind of their take-home point was, well, dupilumab did a little better than omalizumab, but the omalizumab patients were a little bit more severe. The other thing that was interesting was that, like most people in this study, were on concomitant medication. So if you look, like 80-ish% of them were on in the omalizumab group. 83% were on systemic steroids versus about 60% in the dupilumab group. And most, a lot of them were on topical steroids. There was some methotrexate, some mycophenolate mofetil. So, I thought this was good because this is, to be honest, probably how we're going to use these drugs in the real world, is not as monotherapy. We're going to use them. It would be nice to see like a little more quantitative answer as to what minimal therapy means, or, to see a little more ability to quantitate things like how much was your steroid dose reduced, how much was your CellCept reduced. But, that's also harder to do in a retrospective setting.
So it's not like Xolair is being pursued for pemphigoid as a indication, correct? So there's not really like the idea of comparing the two of them. Xolair's never going to be. We're never going to be in a situation where you're like, well, should I start him on Dupy or should I start him on Xolair? Because the Xolair is going to be next to impossible to get, and the Dupy will be less impossible to get, but still difficult. Is that about right?
Yes, I think that given the new indication for Dupilumab, which just, came out, I can't imagine a world in which you would say, what should I start with? Should I start with Xolair or start with Dupixent? But I think it's helpful to understand how this works in context because as we know with these complex diseases, even things like psoriasis, you can have a great biologic, but not everybody's a responder. It also would, suggest that like that might be a good second line. And then again, realize like these were patients who were treated years ago before we had an indication for any of these.
Worked in the long-ish term, worked in like if you put together the complete remission on minimal therapy and the complete remission off therapy, worked in like 90% of people. So then the question is, in the real trial, how well did it work? And that hasn't been published yet, but we're going to talk about it for sure. But Dr. Patton, why don't you tell us about how the Dupy for pemphigoid trial was set up?
Yeah, okay. So I will my deep dive paper was from Advances in Therapies, titled A Study Design of a Phase 2/3 Randomized Controlled Trial of Dupilumab in Adults with Bullous Pemphigoid, Liberty-BP Adept. It was published last year, lead author Muriel. Fair number of Regeneron employees also as authors. It outlined the protocol that was used to evaluate the efficacy of Dupy in the treatment of BP. Design is pretty straightforward. Patients had 35-day pre-screening period. They had to be off moderate to potent topical steroids and or systemic steroids for at least 1 week. And then everybody was given a systemic steroid regimen for 4 to 6 weeks. The initial dose of the steroids was based on the severity of the pemphigoid and also if they initially didn't respond to that initial dose. After which,
So wait,
go
wait.
ahead.
They started both the steroid and the Dupy at the same time.
Yeah, steroid Dupy starting week 0.
And if they
Steroid
had
placebo.
And then if
Same
they
time.
had bad disease, they started higher steroid. If they had not terrible disease and they didn't get better quickly, then they got the higher dose steroid.
Mm-hmm. That's correct.
All right. And then they were on the steroid for how long?
4 to 6 weeks. You had to reach a certain period before you could start to taper the prednisone. So, the original design was at that 6-week period you start, but based on how they did it, there were some patients at 4 weeks where they were able to start tapering the prednisone with the goal of being off steroids by week 16. As we already said, half the patients received Dupy in the same manner that Dupy is always given, the loading dose, and then 300 milligrams every other week. Primary endpoint was the proportion of patients in what they called complete sustained remission at week 36. So there were 3 things that you had to meet to meet that criteria. You had to be off steroids by week 16 with no clinical evidence of disease activity. You had to go without relapse or the need for rescue therapy through week 36. So that's 3 things. The taper off of steroids with no clinical evidence by week 16, and then no relapse, and then no need for rescue therapy through week 36.
So basically, you had to be completely tapered off of systemic steroids and completely clear by week 16. And then you had to stay completely clear with not needing anything else out to week 36.
Yeah, and it's kind of weird. So when you look at you had to go without relapse or need for rescue therapy, well, why else would you give somebody rescue therapy if they didn't relapse? So isn't that kind of the same thing? But you could have, maybe disease activity flare up that wasn't as bad, like it didn't meet the specific definition for what they called a relapse, which I don't really want to get into now. Maybe when we bring Dr. Culton on, we can talk about that. So right. Yeah, that's pretty much it. So, could you have a little flare that didn't require rescue therapy? Yes, could you give somebody rescue therapy even though they technically didn't meet relapse, right? So if they got really itchy, for instance, and you gave them rescue therapy to treat that itchiness, technically that isn't a relapse, but you did give them rescue therapy, so they are a little bit different.
Okay, all right. So
Yeah, inclusion, exclusion criteria. I mean, the list of that is all in the paper, pretty straightforward. Relatively, I guess, moderate BP. It was a BP dye of 24. Now, the highest you could be on a BP dye is 360. So it's nowhere near like the worst of the worst pemphigoid, but I think it would have been hard to do that, to bring in those sort of severity of patients. But yeah, that's pretty much it.
all right, so reasonably complicated. I hate to put it that way, but that's pretty complicated for a normal clinical trial compared to just randomized, double-blind, placebo-controlled for the first 16 weeks. The idea that there was the steroid run-in and then the steroid taper, it's interesting. It's interesting. I've never seen a trial in derm designed like this. We almost always get monotherapy.
Yeah, because I think, to Regeneron's credit, they didn't want patients to have pemphigoid that was, let's say Dupy didn't work at all. Then you have untreated pemphigoid patients in a trial, and you just can't do that with pemphigoid. Those patients can wind up in the hospital. So how do you evaluate a drug when you're also giving it with what is a very, very effective medication that is prednisone?
All right. So after all of that lead up, let's get our guest in, Dr. Donna Culton. So Donna is faculty at the University of North Carolina, where she runs a blistering disease clinic and is very active in the blistering disease world as well. We all just had the pleasure of hearing her lecture at the Maui Derm NPPA meeting. So, Dr. Culton, great to have you on the show.
Yeah, so glad to be here.
And I have to throw in, Dr. Culton also runs the clinical trials, is the co-director of the clinical trials unit at the University of North Carolina. And she also runs the immunofluorescence lab. So I think one of few dermatologists who actually run an immunofluorescence lab, which is kind of a cool niche. Yeah.
I'm impressed.
Very diversified. Yeah.
I am impressed. So, Dr. Cole, were you an investigator in the Dupy pemphigoid trials?
I was.
All right. So I think probably the $1 million question, maybe the $1 billion question that we all want to know. So the data hasn't been published in a peer-reviewed format yet. So how well does it work? That's what we all want to know.
Yeah. So I think there's how well did it work in the study, and then there's how well does it work in real life. And I would say, some of people have been using it off label for years now for bullous pemphigoid. Access is really difficult. So if you are able to get samples, maybe that's something that you can do off label. We do not have samples. And so I've not really had the experience using it before this study. And so, but I agree with kind of what's been talked about is the way the study was designed is everybody started on prednisone. And the idea was everybody should get to a disease control on prednisone. And then the prednisone taper would begin, and hopefully Dupy would hold people remission. And so, in real life, we know there's going to be little trip ups along the way. The way this study was designed, there could be no faltering. Like everything had to go perfectly. They had to reach disease control. The taper had to begin. They could not go backwards on the taper. So as they were tapering down, if they, could not have a relapse, they could not have to go back up on the taper. So everything had to go perfectly. And because of that, the endpoints were, super strict. And so the press release that we have, the numbers of Dupy success were, I think, not as high as we would expect based on some of these real world case series and case reports and retrospective reviews that are out there. And so I think that's the difference. So I think Dupy is going to be super helpful, and would love to hear, you guys' experience, especially Tim, your experience, because I know you treat a lot of these patients as well. But I think in real world, it's going to perform better than what we saw in the clinical trial, at least in.
Yeah, it's my initial experience with Dupy, and I think it was just a factor of being a referral center is I think people were using it off label. People were able to get their patient samples, or were able to say maybe there's a component of atopic dermatitis because I did a biopsy and there was some sponge derm. And, you could make an argument, okay, there's a component. Yes, they have BP, no question, but maybe there's a component of atopic dermatitis that is making this a little bit harder to control. I think that was the justification to get it covered by insurance. But I saw a lot of patients with bad disease who had been on Dupi. That makes sense. I started talking to community dermatologists, and then I started to hear these anecdotal reports of excellent disease control with Dupi. So it was I was getting two separate sort of personal experiences. Yeah, I'm a little bit worried. I actually heard a lecture the other day about Dupi and BP, and somebody saying, well, this is great because, of course, we'd rather use Dupi than steroids. And that's what I'm a little bit worried about, is that was not, it was not what the study looked at, right? This was Dupi in conjunction with steroids. And that's what the endpoints of the trial were. So what we can say now is, Dupi, while giving steroids, may give us these particular endpoints that are going to help us manage these patients. But it's a very sort of specific, regimen that this study looked at. And I think we're going to just figure out from real world experience how we're going to use Dupi. Are we going to give it to every BP patient? Are we going to give it to the patient who just, do we treat with monotherapy prednisone and not add the Dupi right away? Where does rituximab play? Because rituximab I can get covered. I don't know what it's like in North Carolina, but I can get rituximab for BP patients. And if that offers us, decrease in antibody titers, more higher percentage of patients that actually reach remission because those titers are gone and we can get them off prednisone. Where's Dupi going to fall in if we're able to get our patients rituximab? I think it's going to be really interesting. I'm glad we, have a medication that is FDA approved. I think it's pretty exciting. I'm curious to see where we go from here.
So Donna, how are you going to, so next, pemphigoid, we'll call it as close as you can get to run of the mill pemphigoid. So, good number of blisters, but they're not like, oh my God, do I have to send you to the hospital? What are what is it? Prednisone plus doxyniacinamide and then and topical steroids and see him back in 6 weeks. What are you going to be doing? What are you going to be doing?
I mean, we're all trying to figure out where Dupi's going to fall in our treatment algorithm. And I think, right, a lot of us feel like it is what you just suggested, I think is pretty reasonable, right? So maybe somebody comes in with relatively mild to moderate, but on the lower end of moderate. You might try doxyniacinamide first. But I think I'm going to have a low threshold to just go ahead and start Dupi first line. Because and maybe it's a referral bias. A lot of the patients I get have not responded well to doxyniacinamide. So I get them after that already hasn't worked. And so maybe out there in the real world, like it works pretty great. I'm only getting the people it didn't work for. But I, if a patient has needle phobia or some other reason why they don't want to be on Dupi, but my guess is I'm going to start trying to get it first line for patients, if they have disease that is beyond what topicals can handle. And I probably will, unless there's some major contraindication, use it with steroids as some sort of bridge. Again, I don't know how it's going to work if you just did Dupi without steroids. I agree with Tim. Like that's probably, it's not how it was tested. And even in the real world studies that are out there, they're almost all on steroids as well. So it might be one of those drugs that can like hold it once it's cleared with steroids. But, I don't know that we know, can it do all the work from the get-go?
Well, what do you guys?
Go ahead, Matt.
Go ahead. No, go ahead first.
Are we going to be able to tell from the data, like once they sort of have the final publication, like monotherapy is not how we treat most complex diseases, right? So basically, the minute that you couldn't come off or continue to taper your prednisone, you were a failure, end of story. Like, are we going to be able to tell? Like, what if the Dupi group had like half of the cumulative steroid dose? That would be like a pretty meaningful endpoint. But are we going to be able to see that, do you think, from the data that were collected?
I do think that data will be there. I think itch scores, right? Like a huge thing. Again, steroids help with itch too, but we know Dupi's going to help with that. And so I think, again, in real life, am I going to slow down the prednisone taper if I need to? Yeah, I will. While we give Dupi a little more time, but I think everybody's end goal is always going to be to get their patients off of corticosteroids. Would we tolerate a lower dose of corticosteroids? We would probably, right? Like if you could get them down to 5 milligrams a day, is that good with such a safety? Because we haven't really even touched on safety, right? So it's such a safe drug. I love methotrexate. I am a methotrexate fan, and I use a ton of it, and I renally dose it in patients with renal disease. Like I'm not afraid to use it, and I think it works pretty well. But there's no comparison when it comes to safety. It's kind of how I feel about it with Dupi. So I'm going to be transitioning over, and might I throw a little methotrexate in there? Maybe I might do that. So we'll see. But yeah, no, I think we'll have some of that data. It'll be really interesting to see. Again, the study was not designed to allow people to stay on a low dose of prednisone or steroids, just because we had other studies in autoimmune blistering where that allowance of somebody to stay at 5 milligrams a day, it masked the difference between the treatment and the placebo group. Turns out 5 milligrams a day can hold a lot of people. Yeah.
Huh.
If you taper slowly enough, you think.
If you taper slowly,
Yeah.
it can. And in clinical practice, I don't know, Tim, how you've had the experience, but I don't get nervous in the beginning of the taper. I get nervous at the end of the taper. And I will always say the 5 milligrams is the glue that holds it all together. And you might think it's nothing, and then you stop it, and then the blisters come back. So I've seen that in practice.
I know. I love when the new residents come in and they're like, 5 milligrams is subphysiologic, so we're actually not giving them anything. I'm like, trust me, I know, right? That's what we learned, right? But don't you have the 3 milligram patient, the 2 milligram patient?
Yeah.
I mean, that seems subtherapeutic, but right, they forget to refill it, and they call you and they're like, I'm starting to get itchy and I have a hive, and maybe one of these is a little blister. It's very odd.
Do you guys start at, generally start everybody at 40 and tell them stay on this until your blisters are all healed? And then do you just say start on 40, stay on it till you come back in a month? Like, how do you do the prednisone?
Yeah, it's tricky. I do base it based on disease severity. So I'll go higher in a patient that has more severe disease. So, closer to 0.5 mg per kg if they're more moderate disease. But a lot of times, my goal is to get patients mostly clear on the prednisone, high dose prednisone, before we begin to taper. So I think my pet peeve when we're talking about like training the residents is they want to go ahead and like prescribe the taper. And I'm like, we don't know when the taper can begin. Each patient is a little bit different, and we have to kind of let them get there. Now, the other thing that can change the game is if the patient's like, I'm miserable and I hate you because you put me on this terrible prednisone, get me off, then we'll taper before maybe their disease is clear. But otherwise, I really like disease to be at least disease control, right? So I know we talked about not getting into the nuance of disease control, disease remission, but like they just have to not be getting new blisters, and most of the old blisters have to be healing. Whereas, remission would be no blisters at all. So I don't wait for that, but I do wait for disease control before I start to taper. It does not always go that way. Plenty of times, we see them back and they're like, no, I'm still on my Pred 60, and they're totally clear. They've been clear for weeks, and it just, it doesn't always go as planned, but that's the idea. I don't know, Tim, how do you do it?
Yeah, same exact way. I would say 20 to 40 for most patients. The older and frailer they are, maybe the less severe disease. Sometimes 20 milligrams, honestly, will shut it down. Like they come back in 2 weeks, 4 weeks, and they have no active disease. But 30 to 40 average. And, with the most severe patients, fair number of times they're heading to the hospital. They're covered in blisters. They're in really, really bad shape. And that's when you can give IV 80 milligrams of Solumedrol Q8 hours. Like high dose steroids really do shut down the disease. You just couldn't keep them on it for more than like 5 days. I mean, those are the patients where after 3 days, then we'll transition them to PO. And maybe with that initial severe presentation, you're just going to get them rituximab while they're in the hospital.
Can you guys talk about what your taper looks like after? I think that's one of the things with the little bit that I treat that I've learned is like, you can't be like, we're going to taper you by 10 milligrams a week. Like, can you talk about like how slow that taper should be?
I think it really probably depends on vibes. Are we allowed to say that? Are we young enough?
Oh, yeah.
You can say
It was
anything
all
you
about
want in this
vibes.
podcast. Yeah.
No, but you kind of have a sense of somebody who is at high risk of relapse. So once they're in disease control, I think you can go down by 10 milligram increments until you get to 30. And this, again, just how I was trained, we all trained a little bit different. Once you get to 30, and again, maybe you're only starting at 30, but then I go down by 5 milligrams. And there, I think one of the teachings is that you should be doing every other day tapering. And I find that just incredibly challenging for these older patients. And more often than not, they come back all mixed up. So I have not been doing that as much. And so once I'm at 30, then I go down by 5 milligrams. And does anybody remember Calvin and Hobbes, like such a great cartoon from back in the day? And they played Calvin ball, which they like just made up the rules. I feel like that's kind of what we do with prednisone taper sometimes is like, is it by every week? Is it by every 10 days? Is it by like, we try to make these nice round numbers, but really we're just following the patient. You just don't want to do it so fast that you miss the flare coming is kind of what I think, right? You don't want to like pull the rug out from under them and they think they're doing great, but really you just missed what 10 milligrams would have looked like. You just went so fast, you missed it. I don't know if you agree.
Right. No, I agree. And I think when you were saying 10 and 5, you're talking like every 2 weeks. Sometimes with the lower doses, I'll go a month or, months, right? If they were really bad and you just don't want to get them back to that period where they flare. If they get down to 10 milligrams and they're clear, sometimes in the patient that had a bad sort of experience, you just say, well, you're going to be on 10 for the next 2 months, maybe 3. 10 milligrams, patients do fine. I always notify the primary care physician when I start this. Like these patients are probably going to be on prednisone for the next several months. Shoot me a message if you need that taper to go quicker because of, sugars being high or blood pressure being more difficult to manage. But like not one single time has a PCP called me and said, it's got to be quicker. They just manage that stuff.
And I feel like it's one way or the other. Either the patients hate the prednisone and they want off, and then there's the patients who love it and they're like, I don't see the problem. Just stay on this forever. I'll keep that prednisone 10 forever. And you're the one where
I've never felt better. Yeah. I have more energy and my knees don't hurt.
Yeah. No, they kind of get mad at us when we try to take it away. You're like, but it's really bad long term. No, I think exactly what you said is we're all trying to go for less prednisone always. And it just sometimes you got to go a little.
Have either of you gotten this now, like through insurance, had a BP person come in? I know like it just got approved like days ago, or maybe a week or two ago, but have either of you actually like gotten the approval and how hard was it? So curious.
So we actually had a few approvals before it was, before we got the indication. And it always surprised me because I was very pessimistic. The resident was like, I'm going to prescribe Dupie. I was like, we're never going to get it covered. Good luck fighting that. But sometimes we would get it like with just only bullous pemphigoid as the associated disease. So no prurigo nodularis, no, atopic dermatitis in the background. We didn't link it with any of those and it got approved. So I'm hopeful. I think, if you think about rituximab for pemphigus, initially payers were covering it. There were very few hoops to jump through. And now actually I'm starting to see some of the hoops with their, you can only have this much in this period of time. And we're having to like write the appeal letters and explain the data. So who knows what the trajectory will look like for this, if we'll have, good access initially and then some roadblocks, or maybe the roadblocks will.
Yeah, it's been very hit or miss. I swear there was a period of time where it looked like they just the insurance companies were just going to cover the med. And then I would say the last 3 or 4 patients that I tried to get it for with just the bullous pemphigoid indication, they denied it.
Yeah, we'll see. It'll be interesting. We were talking about like with prurigo nodularis and you have to have 20 nodules, or like atopic dermatitis, you have to have failed X, Y, and Z. Like it'll be interesting to see what.
Yep. All right. So Donna, let's kind of change directions a little bit here. So one of the questions that comes up all the time with bullous pemphigoid is, where do you do the DIF? And I think we all know, right? If they've got a blister and they've got red skin next to the blister, you do the DIF from the red skin right next to the blister. But you see some of these people who really all of the red skin is blistered, and it's just, blister or normal skin next to a blister. Where do you do it in that person?
Right. If they're all blistered, then I go for the normal skin right next to the blister.
And is that just as sensitive, do you think, as if they've got some red skin and you biopsy the red skin, or are you worried you're going to miss the diagnosis if you're biopsying normal skin next to the blister?
I'm not that worried. I mean, the antibodies are not all that smart, right? They're not like drawing a line in the sand and they can't go past it. I don't know. I think there's that positive feedback that I get when I do biopsy, and then I am reading my DIF, my own DIF, and I'm like, ooh, that was a little close. But you just need some intact basement membrane zone. That's really all you need. If you're too close to the blister, the real worry is that you will, in the processing of the tissue, the epithelium will come off, right? If the antibodies are there and we know the antibodies disrupt, and so then you shake it around and you wash the Michelle's media off and all that good stuff. Like, there's a chance that you will, just that agitation, the epithelium will come off. Once that happens, you just can't, whatever you see, you can call it, but you're always like, it might not be real. Lesional skin is known to give false negatives, false positives, whatever. So you just really need something intact, some intact basement membrane zone to be able to call it. So I'm not afraid to go right next to a blister.
Okay. All right. And do all commercial?
When are you ever? Go ahead. Do all
commercial labs now offer BP 180 and BP 230? Is that pretty much your local hospital can get that?
Well, I wouldn't say not all labs, but certainly many of the commercial labs. And if your hospital would then probably send off or to a reference lab. I think the real risk is that you could miss. I really love indirect immunofluorescence. And people are like, well, what's the big difference there? If you're only asking about BP 180, BP 230, you could miss inflammatory EBA. You could miss, there's this new variant described, P200 pemphigoid. Is it, clinically it could look the same, but it could be negative if you're just doing BP 180, BP 230. So I think the benefit of doing an indirect is that you're going to see there's antibodies at the basement membrane zone. If you're doing on salt split skin, you're going to see if they localize to the epithelium, or to the dermal side. And so it gives you a little more information. I don't think it's wrong to do the ELISA, but if it comes back negative and you have a real suspicion that this is an autoimmune process, you have to then chase it down with additional testing. I know, Tim, what do you think about that?
Yeah, I completely agree. I want to say even the ELISA for BP 180, isn't it specifically like the NC16A? So if it's another epitope that the antibody happens to be binding to causing disease, that ELISA actually won't pick up that antibody because
Right.
I think it's very specific to that epitope. So the indirect is just right. You're going to catch a broader sort of array of targets that those antibodies might be binding to.
Yeah. And we sometimes even do, sometimes the indirect from serum is not positive, but we'll sometimes even take blister fluid and do an indirect on blister fluid, and the antibodies are there and you can see them. So that's like a little tip. If you have a patient with very few blisters and you get a negative indirect on serum, you can do that as well.
How do you I don't even know how you would order an indirect immunofluorescence. I doubt you can type that in as an order into your EMR if you're not at a university and send somebody off to
commercial labs have it. Yeah.
Okay.
Can people send it to you, Dr. Culton?
Oh, yeah, they can. I'm not drumming up business. Yeah, most of the reference labs will do it. And then in terms of commercial labs, many of them will do it. And I will say, right, it's something you don't order very often. So you have to dig around and find out what are you actually ordering when you order these antibodies, because they're all called different things. And we all have different, commercial labs available to us wherever we happen to be.
Yeah, so I think for Quest, Quest is pretty popular.
And sometimes what I also do, that's what it's called at some of the other labs that we use as well. But then some of them is like a package, you can order your ELISA and it's all the things, it's BP1, 180, BP230, collagen 7s, like all the things you can order it. And it's like comes all together. I'm sure there's still things we could be missing. So I always go back to DIF. Like you need that DIF. That's going to be your.
So the average person who's in, not like sitting down the hall from you, if they are in Epic and they're putting an order in the computer or in your EMR, you can order anti-epidermal antibodies. You can send that patient to the lab. They will draw their blood. They'll process the serum. They'll send it to the reference lab. And in theory, you'll get that indirect IF.
Maybe, I think it's called something different in every institution. Because like at our institution, it's indirect immunofluorescence is what you're putting in. If you want the ELISA, then that gets sent out to a reference lab. So, and I don't know what it's called at you guys' places.
Right. Or most importantly, what's it called in modernizing medicine?
Yeah. But you ask, whatever you ask, and you say, this is what I'm trying to get. What is this? And I think mostly it's important just to know that they're different, right? Because you order something and then you get a result. And if you don't know exactly what you ordered or where the potential pitfalls are, you could miss.
So when somebody sends you an indirect IF, are you like, let me try to figure out, because you memorize all these things for the boards, there's rat bladder, there's monkey esophagus, there's this, like, is your kind of default, like, I'm doing this on salt split human skin, or what's your default?
Yeah, it depends. So sadly, for a direct immunofluorescence, your differential doesn't matter. If you ask me to do any of the IF labs, you ask to do a direct immunofluorescence, we're doing the same stains on every direct that comes in. Indirect's different. So it matters if you tell me, I think this is pemphigoid, then we're going to do it on salt split skin. And I won't do it on monkey esophagus. Unless that comes back negative and you're like, well, maybe it could be pemphigus. But I think that's actually where the DIF helps us, because if you do the DIF first and you see the staining pattern there, then you kind of know what substrate to run the serum on. So that can be super helpful. But yeah, I think there's times where some new resident is thinking all their best thoughts about all the blistering disorders they ever knew or learned, and they put every single one on the requisition. And then we're testing it on all the different substrates with all the different secondary antibodies, right? Because you get the linear IgA disease is going to be different. You have to check with the secondary antibody against IgA. So it creates a lot of testing and a lot of bills if you don't put exactly what you think's going on. I really do think the direct can help you with that. So a lot of people order indirect trying to avoid having to do a biopsy for direct, but I don't think that's the best.
So let's get back to some things that are probably a little more relevant to most of our listeners. So we talked a little bit earlier about the dipeptidyl peptidase induced pemphigoid. In your experience, what's kind of the, how long is somebody on the dipeptidyl peptidase, or could it be, anywhere from a month to 5 years, or is it usually a pretty long time, or what's your take on it?
I think it's a shorter latency period, like Tim alluded to. I think it's like more like 1 to 6 months after you start those drugs that you would see it. And I will say, though, again, I totally agree with everything that was said. Like, we treat those patients like they have pemphigoid. We try to, get them to stop with their primary care versus prescribing it, get them to stop the culprit drug. And then we begin to taper just like we would if they're controlled on disease. We begin to taper their treatment. And those are people who a lot of times you taper all the way off pretty quickly with no issues and life is good, and they sail off into the sunset. And you think, I guess that gliptin really that was the problem for them. Whereas the checkpoint inhibitors, like you said, much longer latency. And the way that the mechanism of action of a checkpoint inhibitor is like, once you have, like you said, let that genie out of the bottle, you cannot put it back for a lot of patients. So a lot of those patients will have now they have pemphigoid because you set it free. And I think it's really hard to control them by just like stopping the treatment and hoping they get better. You definitely have to treat them. And even then it's a lot of times long. Like classic.
Okay. What is your, do you give every patient a topical steroid?
I don't think yeah. All
right.
I like it. And, sometimes initially there's so much body surface area and they're looking at you with these big tense blisters. Like, you want me to rub the cream all over these spots and I'm going to be all slicked up and not want to sit on my couch. And so, but yes, I do. And I say, it's for your worst spots sometimes, or especially as they're doing better and they just have a few little recalcitrant areas left. Then that's when we really lean in on the topical steroids. But no, I don't give clobetasol from head to toe at the outset. No,
you don't do the Franche regimen.
No, I do not. I do not.
Okay, all right, fair. Let's see. Anything else that we really want to? So it sounds like the big takeaway. If I'm going to ask you for a number. If you had to give me for quote run of the mill pemphigoid, just run of the mill. How frequently? How many people do you think Dupy is going to work in?
I'm going to add my own caveats. Is that if I can use prednisone and topical steroids and take however long I want to taper my prednisone, then I think it's probably going to be.
Okay. Dr. Patton, what do you think?
I was going to go 50%. Yeah, what do I want to say? So you're on the prednisone and you start the Dupy and then you taper and you get off steroids and they're only on Dupy, and that's preventing the relapses. That's preventing having to do any sort of additional rescue therapy. I'm saying half the time Dupy's going to be the answer. And that's what that's where it'll be interesting. So I mean, 60 to 80, it could totally be that number. I honestly have no idea. I think
the trial, were topical steroids allowed at all or no? Nothing. That was considered rescue.
I think they called that rescue therapy.
Okay. And so maybe whenever we put Dupy together with a little bit of doxy and niacinamide, it'll work a little bit better. Who knows? It's kind of one of the big takeaways.
It's all right. Think about I don't know. I think back to psoriasis, and I know in trials you couldn't use it, but if I have somebody who can treat themselves with clobetasol 3 times a week and get 1 or 2 stubborn plaques done, I'm happy with that outcome. I don't consider that a treatment failure. That's what I think is so hard here. And one blister that needed clobetasol and it was a failure.
Well, and we know as dermatologists, we're pretty scrappy and we're going to mix and match and we're going to use all our tools. And so I think in real life, we're going to have a lot more flexibility in how we use everything and in how it works. We're going to see better outcomes.
Yeah, because if they're on the Dupy and they flare and you're like, well, I'm going to put you back on 10. I think in the real world, we're not going to be like, Dupy's not working. Let's just stop it. It's not doing anything. We're going to say, okay, but if you weren't on the Dupy, maybe it would be 30 milligrams that we'd have to keep you on long term. So that's what I think we're going to figure out. I don't know. Donna, do you think antibody, what do I want to say? The tighter spectrum, so some patients will respond better if their 230 is higher than their 180.
Maybe. I mean, I think that's where the fun for us will be as blistering people, right? We get to figure out, we call it disease endotypes, or, who's going to respond to what and who's really more of a type 2 inflammation, and Dupy will be great for them, and other people who maybe that's not really what is driving their disease. So I do think there's going to be some fun to be had in figuring out who Dupy works for and who.
Okay. Well, let's jump over to our patent. Unless Patent Fairs, you guys got anything else before we jump over to our patented patent trivia?
I was so engaged in this conversation. I had no idea what you were kicking it over to. I totally forgot about my trivia.
Sounds right.
Which usually this is the only thing I look forward to on the show. All right. So it is blisters. It's blister trivia.
Okay.
We ready?
Yep.
All right. What song is the first track of the 1983 self-titled debut album by the Violent Femmes?
Blister in the Sun.
Dang it.
Yeah. Blister in the Sun.
On the board.
In my mind, I was thinking it's got to have a Violent Femmes question in it when it said blister. So I was ready.
Steve Ferris is already strategizing.
Exactly.
Yeah.
Exactly.
No, very good. All right. I'm keeping with the music theme. I go away from music theme, third question. And it's actually more medically related. So hang in there if you don't like music. Ringo Starr shouts out the phrase, "I got blisters on my fingers" at the very end of what Beatles track from the White Album?
No idea.
I got
No.
nothing.
Okay. Any track from the White Album? You just want to
Lucy
throw out
in
a
the
guess?
Sky
Anyone?
with Diamonds. That's the only one I can
Yeah.
think of.
Different album, but
Okay. It was the Beatles.
at least you guessed.
Okay.
At least you guessed. Thanks for participating. The song was Helter Skelter.
Ah.
Oh, okay.
Yeah.
Helter Skelter. All right.
Yeah, classic little bit of Beatles trivia there. All right, number 3, oral contraceptive medications were the first types of medications to be distributed in what type of packaging?
Blister packs.
I think
Is that a
Yeah.
tie?
that was
Really
a
bad.
three-way tie. We all got that.
I got Matt first, but I think with delays, and Matt, you're closer to me than
It's true.
the UNC
Right.
people. So
I heard
think it's a
Donna
tie.
first, so there you go. That's the geography.
It
It's true.
is.
It's true.
That's true. All right, so I'm calling it a tie. So that's Ferris's with the
One.
blister in the sun.
All right.
Good work, Ferris.
Thank you.
All right.
All right.
Well, I want to thank our listeners for joining us this week. If you've got questions, comments, or ideas for topics we cover on the show, shoot us an email at questions@dermsondrugs.com. We hope you learned a few things. We hope you laughed once or twice. And mostly, we're hoping you're planning to join us next week. Until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.